Hey everyone, I am back today with more evaluation and management case studies, and today we're going inpatient. We're going to do professional fee E&M. We're going to do an initial, so an admit, a subsequent, and then a discharge for inpatient hospital as well. And today I'm actually going to use the Novitas interactive score sheet. So Novitas is my local Medicare area contractor. You may have a different one in your area, but I find their interactive score sheet very helpful, especially as you're starting out. I'm going to link the interactive score sheet below, and I'm going to give you a link to the cases so that you can follow along. But I think this format will make it just a little bit easier to see exactly what I'm doing as we're going through. I put some test information in here because depending on the date, it might populate a different score sheet because we now have different guidelines for 2021 for office outpatient. So it's going to ask you about that data service. So I'm just putting in generic test information, data service, and is this outpatient? No, because that's going to give us possibly a different score sheet too because of those different guidelines. And then I'm going to hit continue. Next, it's going to ask us about what type of E&M service is this. So we know it's not office outpatient, but this is an initial hospital care. So we're going to click that box right there. And we're going to start scrolling down. First, we're going to score out our history. So our chief complaint is diarrhea, vomiting, and abdominal pain. And that actually right away gives us a location. We have our abdominal pain. Patient is 85-year-old, presents with chief complaint of abdominal pain, and she's had it for 2 days. So that's our duration. Patient is a very poor historian and extremely hard of hearing. So right there, ears, right? And therefore, very little history is available. She was found by EMS sitting on the toilet, having diarrhea, and is also just vomited. So we have associated signs and symptoms. They're vomiting. Upon my questioning of the patient, she can confirm that she's been sick to her stomach and has vomited. She cannot tell me how many times. She also tells me that her belly has been hurting and describes it as sharp. Sharp is a quality. And then we have, I am unable to get any further history of the patient because, again, she's an extremely poor historian and very hard of hearing. So we didn't get a whole lot of stuff, but we got enough here to get us to the extended. So we have here the location. We have the quality. We didn't get severity. Severity would be, is this on the pain scale from 1 to 10? Is it mild, moderate, severe? We don't have timing. And if you hover over these, they'll tell you what these definitions are. So timing is the frequency of the complaint. It doesn't say that she's constantly vomiting. It doesn't say that she's having periodic vomiting. Context is what was kind of happening around the circumstances. So it doesn't say like she ate a heavy meal and started vomiting. She started a new medication and started vomiting. It also doesn't say that she took, Pepto-Bismol and that didn't make it better. So there's no modifying factors either. As far as review of systems, now we can kind of scroll down a little bit more and we'll get to that section here. But first, what we have is our past medical history. So we have past medical history per the EMR, hypertension, diverticulosis, blindness, sciatica. Medications can also be considered past history. Now, allergies can go one of two places. And depending on what you're scoring, you can put it in whatever area might better prove that level. So allergies, we have here under our review of systems, right? We have allergic. It could also go in past history, but we already have other past history. So let's click the box over here, right? We have family history. We have social history. Says that they couldn't get it because she's a poor historian. Now, there are different philosophies on this. What I've been told from my Medicare contractor is that if there's components that they state that they were unable to obtain and they give you a reason why, that they kind of look at the big picture and determine if they can score it or not. I would say in this case, I would give it to them because they're saying this is a poor historian. It doesn't look like there's any family around that they could have asked instead. It's not that they were like, oh, I'm just not going to ask the patient for their social history. They genuinely just couldn't obtain it. Now let's look at the review of systems. Review of systems says positive for stomach pain, which we have here under their GI. And all other systems were reviewed and are negative. So they got the right terminology there. Sometimes providers don't always have the right statement here. They might say other systems were reviewed and are negative or 10 systems reviewed and negative, but it really clearly here has to be all other systems were reviewed, all others were negative. So here that's going to take us to a comprehensive history level. And now let's move down to our exam. So on our exam now, we have here vitals, so that's our constitutional. And we also have general, which is still constitution, elderly black female, initially sleeping upon my evaluation, but is easily arousable. We have the neck, so no JVD, no thyromegaly. Ears, nose, and throat, oropharynx is dry. Her hearing is very diminished, okay? And then we have cardiovascular. So cardiovascular is here. Regular rhythm, no lower extremity edema. So we can say that he did one extremity. This isn't plural, so it's hard to tell if he did, assumedly he did both lower extremities, but it's not 100% clear. So I'll give him credit for one extremity, but I'm not going to give both. It probably won't make a difference because it looks like we're going to score higher on organ systems versus our body areas. GI, mild epigastric tenderness to palpation without guarding or rebound. Bowel sounds are normal and reactive, so we get GI. Over here we get abdomen. And remember, we can't mix or match these. It either has to be body areas or organ systems. Respiratory, clear to auscultation bilaterally without a normal effect. Skin, warm and dry. Musculoskeletal, ambulates appropriately. Neurologic, patient attempts to answer questions when asked, but is very hard of hearing. She is seen to move all extremities spontaneously and appears without focal neurological deficits. So right there you can see we jumped up to our comprehensive. Even though we didn't do so well in body areas, it's going to calculate out whichever one we did the higher score on, which was our organ systems. If you need to score based off of the 4x4 exam, which is a Novitas criteria and not for all areas, but it will give you information here if you click on it about how they use this 4x4 method to calculate a detailed examination. And you can click this box here to calculate if it has 4 or more documented elements. Now, down to our medical decision making. Here we go. So we have some labs here. And it says also here an EKG shows normal sinus rhythm. And it says lab data and EKG were personally reviewed by me, which I like because that's very helpful. There's a lot of electronic medical record systems now that will just automatically pull in data and you can't tell if the provider actually reviewed it because it just dumps in. So there's a lot more auditing that's going on, that's looking at the trails in the EMR where they can tell, hey, that data just dumped in. That doesn't tell me that you reviewed it. It just tells me you plopped it into the medical record to fluff it up. So there is more scrutiny going on now as far as saying, hey, we know all that lab data is there. Did you actually review it? And the way to verify that is by putting in a statement saying, yes, I reviewed the lab data. Yes, I reviewed this imaging, etc. Now, again, we're just focusing on the E&M level today. We're not going to do the ICD-10-CM codes. Normally, you would code these out, but I think if I were to demonstrate how to look up all of these different diagnosis codes, it would be a very, very long video. So let's see. We have our lab data, so we can check here, review our order of clinical labs. And an EKG is actually in the medicine section of CPT, so we get 1 point there as well. Now, is this patient having a self-limited problem, an established problem to the examiner that's stable, worsening, or is it a new problem with no workup or a new problem with additional workup? So it's going to be one of these two because this is their first visit with this new abdominal pain and it's either going to be no additional workup or we're going to do some workup. What is workup? Well, workup is basically anything done beyond that encounter that we're working up that patient, that we're ordering studies, that we're ordering labs, that we're going, hey, we need to figure out what this abdominal pain is exactly. So we're going to do some additional working up of this patient. So let's see here. We have pancreatitis. They're treating it with morphine and Zofran. Diarrhea, they're going to check some stool studies. They're doing IVs. They don't know if the patient's diabetic. They're going to do sliding scale insulin. Let's see here. They're going to do IV fluids. They're checking her calcium levels. They're doing some multiple myeloma, having discussion with the family. So I would say, this doesn't really look like they're doing a lot of additional workup. When they're saying, we'll check stool studies, that's not them saying that they're ordering some additional workup. They are not ordering stool studies. They're just saying they're going to check the stool studies. I could see the argument for maybe it being additional workup, but I think we're going to go on the safe side for this one and say that it's a new problem, no additional workup. Now we do have down here it says that they're seeking hospice placement and that they want to discuss it with the family, but it doesn't say that they did discuss it with the family. So we have a lot of conditions here that the patient has new, but we're not doing workup for 1, 2, 3, 4, 5, etc. So whether we put 1 here, we put 2 here, we put 6 here, and actually let's put 6 here and see what happens. There's a maximum of 1 new problem with no additional workup. So even if we put 6 there, it's going to rule us out. See, even if we put 2 there, no, it only allows a maximum of 1. So we're going to get a total of 3 here because we don't have any established problems to this provider and we don't have any new that we're doing workup on. Now, as far as other components here, we are not reviewing or ordering x-rays. I didn't see any test studies done with the provider. I'm not seeing any reviews of old records or obtaining history from someone other than the patient. There's no summarization of any old records. It says here about obtaining history from someone other than the patient or discussion of the case with another healthcare provider. Here it says that I would have to discuss with the family, but it doesn't have any description of a conversation that was had with the family. And we don't have an independent visualization of the image tracing or specimen, not simply review of the report. So it says they reviewed. It doesn't say that they looked at the imaging though. So that's what we would need to count as an independent visualization of an image. So as far as risk, the presenting problem here was at minimal, low, moderate, or high. So we've got this abdominal pain, but we're saying now it's pancreatitis. So we've got pancreatitis and we've got hypertension. So that's 2 chronic conditions. Now, granted, they're not probably what we would describe as stable, but they're not to such a level that we have a severe exacerbation and we could say, oh yeah, we can count it as high. I think this is really more so a moderate level. We're not ordering any diagnostic procedures. Let's take a look here. Did we do labs, x-rays? Not really seeing a lot ordered. And we only need 2 out of the 3 here. So what are our management options? We definitely have some prescription drugs, right? Morphine, Zofran, etc. We're not doing major surgery. If he had documented more proficiently that they are de-escalating this care and putting them in hospice because there's this poor prognosis, we could have maybe hit it high here, but this is just saying, the family's thinking about hospice planning right now or hospice placement. It's not really saying, oh yeah, we're definitely de-escalating this care right now. So I would count this more as a moderate because of the prescription drug management that we're doing. That's a pretty easy one to hit because almost all patients that are in the hospital are on some kind of prescription drug, right? Otherwise, they might not be in the hospital. So when we go down here, we don't have any time documented. So we're going to go to our 95 guidelines, comprehensive history, comprehensive exam, moderate level decision making, and it's going to give us a 99222. And don't forget that we have the AI modifier for inpatient services, which indicates that this was an admit. Because since Medicare doesn't accept consultation codes anymore, sometimes our consults are billed as inpatient. So since this is a genuine hospital admission and not a consult that we're billing as an admission, because Medicare doesn't take consult codes, we use that AI modifier. So now let's clear our score sheet and we're going to go back. We're going to put in our test information here, our test date of service, and we're going to put in not office and that it is a test complaint, and we're going to hit continue. And now instead of hitting our initial, we're going to hit for the subsequent hospital care. Subsequent hospitals are interesting because you only are required to do an interval history, which means basically you don't have to repeat the past family social history for subsequent hospital visits in order to hit the levels of service. So we're going to just focus on the HPI and the review of systems in order to get a high level of the history. So you'll see a lot of times they don't document the past family and social history because it's not needed for that level of service. So this patient is hospitalist follow-up. continuing issues with atrial flutter, rapid ventricular response, resistant to treatment, followed by Dr. X of cardiology throughout most of the day. This afternoon, when I am seeing the patient, nursing informs me that the rate has been controlled, but systolic blood pressures have dropped to the 70s. So this is a lot of information that's not really fitting into our HPI criteria yet, right? Dr. X was consulted from the bedside. We agreed to try fluid boluses and then to consider neosyphrin pressure support if not successful. In addition, over the last 24 hours, extensive discussions have been held with the family and questions answered by nursing staff concerning the patient's possible move to Tahoe Pacific or long-term acute care. Other issues requiring following up today are elevated transaminase, continuing fever, pneumonia, resolving adult respiratory distress syndrome, ventilator-dependent respiratory failure, hypokalemia, non-STEMI, hypernatremia, etc., 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 etc. So this kind of gives us a predicament, right? Because we're looking at this and we're not hitting our usual kind of bullets that we hit. Now, granted, for subsequence, we only need 2 out of 3 out of history exam medical decision making. So maybe if he did a really good exam, an MDM, if he's not hitting a lot of this stuff up here, probably not so bad. Do we have the status of chronic conditions? Well, here we have that they have some chronic conditions. We might, as we go through, see maybe they give a good status of it in the A&P area. But let's see here. What can we get? So any HPI elements, continuing issues with atrial flutter. Okay, so we have a location. This is an atrial flutter, so it's a cardiac issue. Seeing the patient controlled. Looks like that we might hit some components here for discussion of the case with another provider. Other acute issues there, elevated transaminase, continuing fever. The fever is more so an exam finding than it is the patient complaining of fever. So a lot of this is really more so provider findings and provider discussion versus patient reported complaints, which is really what the review of systems is supposed to be. It's supposed to be the patient's stated, oh, I'm having trouble breathing, oh, I'm having GI issues, etc. These are provider documented. So I can maybe count for the location. I'm not so sure about some of these other areas. I don't know, maybe you have a different opinion. You can pick something else out of there. So for exam, we have our vitals, which is our constitution. Same with general. Patient is much more alert appearing than my last examination. Denies any pain, appears to have intact mentation, and there is no apparent distress. So psych. Eyes, pupils are round, reactive to light accommodation. We have ENT, oral mucosa, and we have posterior pharynx is clear. We have cardiovascular. We have respiratory for the lungs. Abdomen is distended. So we have abdomen there. We have skin is warm and dry. We have extremities. Now this is plural, but I don't know exactly how many. So I'm going to count for at least 2. Again, it looks like organ systems are probably going to do better. We have show trace edema with no clubbing or cyanosis. That's actually still cardiovascular. So as edema is a cardiovascular condition. So we can't count that there, but we do have neurological, patients moving all extremities without focal neurological deficits. So we've hit at least our 8. So we have our comprehensive over here. Now, some of you may have things that you would count for different areas. I've had some people respond and say, hey, I would not count this distress as psych because I think that's respiratory distress. So, all in all, it will probably score out to the same level since we have a good, very robust physical examination here. Now, here we have our lab data. We have here sodium, potassium, etc. Also noted is a scant amount of very concentrated appearing urine in the bag. That looks to me more like a provider documented statement versus just them pulling in that lab data. So I think when we get down here, we could probably count for a review of the lab data. Overall impressions continues to be critically ill 67-year-old with multiple medical problems, still showing signs of volume depletion with hypotension and atrial flutter with difficult to control rate. So let's take a look here. Let's go to our problems. Do we have established or do we have new, and are they additional workup? No additional workup. Well, it says he examined this patient 3 weeks ago, right? So these are all established problems unless we have something new that has developed since the past 3 weeks, or if it is, maybe an exacerbation of a problem. But let's see here. It says here that he looked at this patient. I know I saw it here, that he saw him 3 weeks ago. Yeah, so it said here, patient is much more alert appearing than my last examination of approximately 3 weeks ago. So assuming these are all established from 3 weeks ago, we would count these as established problems, unless we could further divulge into the electronic medical record system and determine that maybe some of them might be new. But let's see, we have established problems. Hypotension, now we need to determine, are they stable or are they worsening? So hypotension, does it say it's worsening? It doesn't say if it's worsening since last time. Ultrasound was negative. Continue antibiotics. He is not exceptionally toxic. This one he definitely says improved. Patient has received a tracheostomy. This is resolved, so that we wouldn't even code. This is improving. Finger stick blood glucoses are reviewed. Continue current management. Critically ill patient with multi-organ dysfunction and signs of worsening. Okay, here we go. Signs of worsening renal, hepatic, and cardiovascular function. So anything that we could say is renal, hepatic, or cardiovascular, he's saying is worsening. The hypotension, so the hypotension would be cardiovascular, so that's worsening. So we can count that as our worsening, established worsening. Transaminase, let's see. That's function of the liver, so that's worsening, hepatic. So we're going to bump that up to 2. Fever and elevated white blood cell count, that really is more so stable. Ventilator-dependent respiratory failure, that to me looks more so stable because now they're being managed on the vent. Hypokalemia has resolved. We're not going to count that. Hypernatremia is improving. So there's another stable or improving. We're going to bump that up to 3. And then diabetes, it says continue current management. So that'll go up to 4. So where are we at right here? So we've got a total of 7. We're way above and beyond where we need to be for our extensive number of diagnoses or treatment options. We only need a 4 here to get the extensive, so we definitely have at least an extensive level here. Now, you may have considered things a little bit differently. Again, E&M coding is subjective. You may have a different interpretation than I do. Now, let's see, as far as our data, did we order any tests in the radiology section? I don't think I saw any, but I may have missed one. I don't think it'll make a level difference, honestly, if I do. We definitely had those discussions with the other provider. I remember seeing those. Review and summarization of old records, or obtaining history from someone, or discussion of the case with another healthcare provider. Remember, he talked about that conversation he was having with Dr. X. So he talks about Dr. X here. He talks about the conversation that he was having with Dr. X on the bedside, and that they were having this conversation about the patient. He details what's going on, not just said, I had the conversation with Dr. X. We do have that summarization of what he discussed. Not sure about independent visualization of any imaging or tracing or specimens. We didn't discuss test results with the performing physician. We did not summarize old records or obtain history from someone other than the patient. So it looks like we've got a 3 here. We've got multiple amount of complexity of data. I'm just going to double check here and make sure I didn't miss anything. We didn't have any radiology tests. We didn't do an EKG or any medicine section stuff here. So let's take a look here. We're probably going to hit it here with our risk of complications. What have we got? We've got a patient here. Critically ill patient with multi-organ dysfunction and signs of worsening hepatic, renal, and cardiovascular function. So presenting problem, we would say here we have 1 or more chronic illnesses with severe exacerbation. Does it say severe exacerbation? So it doesn't say that word severe, but it does say the patient's critically ill. Do we have an acute or chronic illness or injuries that may pose a threat to life or bodily function? Pulmonary embolus, severe respiratory distress. This one's kind of a tough one. Psychiatric illness with potential threat to others. One or more chronic illnesses with a severe exacerbation, progression, or side effects of treatment. I think just stating that the patient is critically ill alone and multi-organ dysfunction and signs of worsening hepatic or renal failure with extremely guarded prognosis. It says guarded prognosis. I'm just not seeing where it would be a severe exacerbation or progression because a lot of this is improving. Look, it says here he's improved since my last examination. The hypokalemia is resolved. This is improving. So I'm just not seeing that this is a high risk. I'm seeing moderate risk here. So I'm thinking moderate. As far as diagnostic procedures ordered, let's see here. We're getting fluids. They reviewed an ultrasound. That wasn't an order. Let's see here. Continue. Blood glucoses are at normal, multi-organ dysfunction, and signs of worsening renal. So I'm not seeing a lot of diagnostic procedures ordered. Management options, we definitely have at least that moderate for the prescription drug management. We're not doing elective surgery. We're not doing monitoring for toxicity because they're on very regimented drug therapy. We're not doing a DNR or de-escalating care. So I think in this case, again, it's more of our moderate level. So that'll bring us to a 99232 level of service because we have a problem-focused history, comprehensive exam, and moderate level decision making. Now, let me look at one other thing though. So we do have some chronic conditions here. I think maybe even if we were to go back and say, oh yeah, we're going to count some of these chronic conditions like the diabetes, even if we counted the 3 chronic conditions, it still wouldn't bring up, and even if we count like one review of systems, it still wouldn't bring it up to that level 3 service, you see? So I think even if there's a couple of items here that maybe you would say, okay, I would squeak this and I would squeak this, it's still not going to bring them up to that level that they need to hit a level 3. So I'm pretty confident with the 99232 for this one. Now, the last one we're going to do is a hospital inpatient discharge, and we actually can't use the score sheet for this one because they are just coded based off of time. So if we look at our CPT book, we have 2 codes: hospital discharge day management, 30 minutes or less, and more than 30 minutes. So really all we're going to be looking for is the time component in order to pick out the E&M service. So is it 30 minutes or less, or is it 31 and up? So more than 31 minutes. So let's take a look at our note here. There's a lot of information, but what we're really going to be doing is just kind of scanning to see that time component. Do they have the time documented? So usually what I see is the providers typically put the time at the bottom. I spent 36 minutes in total time in discharge planning, including getting labs and orders and discharge paperwork, etc. And that's usually documented at the end. So it says here we don't have anything. We have a lot of information about their discharge instructions, but we don't have time. So what do we do in that circumstance? Well, in that circumstance, we bill it to the 99238, which is our one that we have the 30 minutes or less. So we can't quantify the time, so we bill it as a 99238. So that's it for the inpatient, for the admit, the subsequent, and the discharge. I really hope you enjoyed this video. I love doing case studies, but they can be difficult because people just have different interpretations of things. So if you have different interpretations, let me know in the comments. I'm always happy to see kind of where your references are. And if you need more support on evaluation and management services, I have an entire playlist. You're going to want to check that one out right there. I will see you guys in the next video. And until then, just keep on coding on.